BRAF mutations are found in about 4% of patients with non-small cell lung cancer. One important point to draw contrast with melanoma, where BRAF mutations are found in about 50% of patients, is that not all BRAF mutations in lung cancer are V600E. In fact, only about 50% of lung cancers with BRAF mutations will actually have the canonical V600E mutation. So that really brings down the frequency to about 2% of patients will have BRAF V600E. In general, these patients tend to have characteristic clinical characteristics. In contrast to EGFR, ALK, and ROS1, we do observe BRAF mutations in patients with a history of smoking. But we also know that BRAF mutations do confer sensitivity to treatment with targeted therapies, specifically BRAF inhibitors as well as MEK inhibitors. So we've learned early on from our colleagues treating melanoma that BRAF inhibitors can induce responses to tumors harboring V600E mutations, most notably in melanoma and non-small cell lung cancer. We've seen in non-small cell lung cancer as well as in melanoma that the combination of BRAF plus MEK actually results in better activity as well as better tolerability. And this results from blocking downstream of the mutant BRAF with a MEK inhibitor. So in the United States, the combination of dabrafenib and trametinib is currently approved for patients with BRAF V600E non-small cell lung cancer. And I should note that this is different than the experience in colon cancer. So I think BRAF is a helpful lesson for targeted therapies more broadly, because we know that the same genetic alteration can behave very differently depending upon the tumor in which it occurs in. So BRAF V600E in melanoma and in non-small cell lung cancer is very sensitive to treatment with BRAF plus MEK. By contrast, the same mutation in colorectal cancer is far less sensitive to targeted therapies. And so I do think that it's an important reminder that we need to actually do clinical trials of genetic alterations across different diseases because they may behave quite differently.
BRAF mutant lung cancers include a proportion of patients that have BRAF V600E mutations in their tumors. And this has been well known to be a target in the melanoma world. We found that these mutations can occur in non-small cell lung cancers up to a frequency of about 2%, depending on the series that you look at. We know that these are highly actionable, and if you give a single agent BRAF inhibitor like vemurafenib or dabrafenib, you might achieve response rates of approximately 30%. However, following the lead again of what we've seen in the melanoma world, when you give a combination of a BRAF and a MEK inhibitor, specifically dabrafenib and trametinib, we know that the response rate more than doubles to 63% with that combination in the phase 2 setting. And so that's currently approved by the FDA for the treatment of BRAF V600E mutant lung cancer patients, and would be my first choice for someone that's stage 4 and treatment naive, knowing that the outcomes that we're seeing with a combination parallel the outcomes that we've seen with tyrosine kinase inhibitor therapy for EGFR and ALK and ROS1.
For non-V600E BRAF mutations, currently the standard of care would be the default standard of care chemotherapy or immunotherapy or combination of the two. There are actually many different types of non-V600E mutations, and they generally fall into 3 different classes. And the approaches to each of those classes is different. But right now, there's no currently FDA-approved therapy for non-V600E mutations. And so if I were to encounter one of those patients, I would actually direct them to a clinical trial. But the standard of care to start would be as I would be approaching a wild-type patient.